Hello everyone. As we all know, today on 29th of January, we'll be observing World Leprosy Day. So let's discuss about the National Leprosy Eradication Program of India. Let's see the data related to new leprosy cases and grade 2 disability in India. So when we see the new leprosy cases in India, so among all the states, Maharashtra comes on the top, followed by Uttar Pradesh, Bihar, Odisha, Madhya Pradesh, Chhattisgarh, Jharkhand, and so on. When we see the data related to grade 2 disability in the terms of absolute number for the year 2021 in India, so in that the Bihar comes first, followed by Maharashtra, Odisha, Chhattisgarh, Madhya Pradesh, Jharkhand, and so on. So the top 7 states in terms of new leprosy cases and grade 2 disability are Maharashtra, Uttar Pradesh, Bihar, Odisha, Madhya Pradesh, Chhattisgarh, and Jharkhand. When we map all the districts of India in terms of level of endemicity of leprosy, so we found that out of all these 708 districts of India, there are 118 districts we are highly endemic, and these highly endemic districts are distributed along with states of Maharashtra, Madhya Pradesh, Chhattisgarh, Odisha, Andhra Pradesh, West Bengal, Bihar, and UP. Let's see some data with respect to leprosy in India. So, India is the highest leprosy burden country in the world. It consists of approx 58% of new cases of the world, and it has prevalence rate of approx 0.4 per 10,000 population with visible deformity 2.41%. When we see the annual new case detection rate, so it is approx 4.56 per 1 lakh population, and rate of visible deformity, it is around 1.1 per million population, per 10 lakh population. Among all the states of India, the Bihar, Madhya Pradesh, Maharashtra, UP, Odisha, Chhattisgarh, West Bengal, and Jharkhand, they are on top 7, as I have already mentioned in previous slide, and all these 7 states, they contribute approx 76% of the cases of leprosy. Let's see some milestones in respect of leprosy in India. So in 1948, Hindu Kush Nivaran Sangh was established. In 1955, India started its National Leprosy Control Program. Follow to that, after introduction of MDT, multi-drug therapy, in the year 1982, India started its program, that is National Leprosy Eradication Program, NLEP, and presently this program is running in India. Apart from that, there are some other milestones in India. These are the milestones related with leprosy in India. Now we'll discuss in detail about the NLEP in India. So NLEP is a centrally sponsored public health program, and as I have already mentioned, this was introduced in the year 1983, and there have been lots of remarkable changes from NLCP, National Leprosy Control Program, which was introduced in 1955, to National Leprosy Eradication Program in 1983. And this National Leprosy Eradication Program, this comes under the umbrella of NHM, that is National Health Mission, and all the activities of NLEP are planned, implemented, and monitored under this broad umbrella program, that is NHM. Here we can see the emblem of NLEP. In this emblem, this lotus this symbolizes the beauty and purity in the lotus. We can see here one structure similar to house, and it says that leprosy can be cured, and the leprosy patient who is presently having leprosy or who has already been cured with leprosy, he can be included as a useful member of the society, even if he is having partially affected thumb, a normal forefinger. Coming to the rising sun in this emblem, this rising sun symbolizes the hope and optimism in a patient of leprosy. Here in this slide, we can see all the components related with the NLEP, National Leprosy Eradication Program. So as I have mentioned that it was introduced in 1983 after MDT introduction. So let's see the vision of National Leprosy Eradication Program. So vision for NLEP is leprosy free India. What is the mission of this NLEP? To provide a quality leprosy service that should be free of cost, and it should be provided to all the sections of the population and with very easy accessibility. Coming to the objectives of NLEP. So first objective is to reduce the prevalence rate to less than 1 per 10,000 population, and this prevalence rate should be less than 1 as per the district level. Second objective is to reduce the grade 2 disability percentage less than 1 among the new cases, and this objective we have to maintain at the national level. Coming to the third objective is to reduce the grade 2 disability cases. Earlier we have seen the grade 2 disability percentage. Here objective is to reduce the grade 2 disability cases less than 1 case per million population. And again this objective includes some sub objectives. They are that we have to maintain the zero disability among the new child cases. In all the new child cases, disability should be nil, and we have also to maintain the stigma and discrimination level to 0. NLEP has some strategy also. So let's see the strategy in the next slide in detail. Let's see the strategies in details. So first strategy is integration and decentralization of all the anti-leprosy services, and this is through general health care system which is presently existing in India. Second strategy is early detection and complete treatment of all the new cases. Third strategy is to carry out the household survey so that we can detect early to all the cases. Fourth strategy is involvement of ASA in the detection and completion of leprosy cases on time. Next strategy is strengthening of disability prevention and medical rehabilitation. Next strategy is IEC, information, education and communication activities, and we have to perform these activities in the community to improve the self-reporting of the cases at PHC level, and also we have to reduce the stigma related with leprosy. The next and final strategy is monitoring. We need to intensify our monitoring and supervision at health and wellness centers and at PHCs and CHCs so that maximum number of leprosy can be detected and can be treated timely. We have some components of this programs. These are case detection and management, DPMR, disability prevention and medical rehabilitation, IC and BCC, information, education, communication and behavioral change communication. Next one is human resource and capacity building. And next is program management. We will see all the program components in detail in subsequent slides. So first program component is case detection activities. So in this we will identify the leprosy suspects. Case diagnosis and confirmation will be done by government or non-government organization, and also by the support of the field workers. Any difficult to diagnose cases, reactions and complications will be identified, and further they will referred to the higher centers. Routine and active survey will be done to identify the cases, detect the cases. In schools, screening of the children will be done to identify the leprosy cases. Apart from that, we will do the contact screening as per the guidelines and other special activities if required. Second component is treatment. So we will initiate the MDT, multi-drug therapy, to the positive leprosy cases. Apart from that, we will also ensure about his compliance to the medications. If there any adverse effects are there due to the medications, we will monitor to that. In case of defaulters, we will identify and retrieve the defaulters to continue their treatment. In case of any complications in leprosy patient, we will identify and treat. We will also ensure about the multi-drug therapy availability, drugs availability. Apart from that, other drugs availability, supportive drugs availability like steroids and others. And we need to ensure that all the medications of leprosy should be free of cost. Next component is capacity building. So we will develop adequate skills among the staff for the proper diagnosis and management of the leprosy cases. We will train the general healthcare staff regarding the leprosy, and this training should be regular and it should be a refreshing kind of training. And apart from that, we will also maintain the data of regarding this training, how many persons trained and how many persons are still need to be trained. So all this data has to be maintained. Next component is disability prevention and medical rehabilitation activities. So this activity will be done at primary, secondary and tertiary level. We will identify the persons having leprosy. We will identify their disability status. We will line list the beneficiaries. We will also the prevention of disability POD activities, so that maximum number of disabilities can be prevented. We will also provide them kits for dressings and also demonstrate them how to use these kits. Apart from that, we will provide them special kind of footwears, micro, cellulose, rubber footwear and other aids and appliances. If any person is requiring reconstructive surgery for the disability, so we will identify the institution for that persons. We will provide the incentives in case of any persons is done of that reconstructive surgery. Present allowance is approx rupees 8,000 per person per surgery. And apart from that, other special activities or programs will be conducted in respect of DPMR. Next component is information, education and communication and behavioral change communication. So these two activities will generate awareness among the people about the leprosy signs and symptoms, its treatment. It will also help us to reduce the stigma and discrimination related with leprosy. And this IEC and BCC campaign can be conducted at school or college level, community level, or it can also by the interpersonal communication. Apart from that, we need to more focus on BCC, that is behavioral change communication. This will definitely help to increase in voluntary reporting among the leprosy cases. Apart from that, we will also be conducting the Spurs Leprosy Awareness Campaign to raise awareness about the leprosy, so that ultimately we can achieve the leprosy free India. The next component is planning, supervision and monitoring. So we have to assess the situation of leprosy in that particular area, and we need to implement the action plan accordingly. This planning can be done through the surveys and field visits to know the actual situation. We need also to supervise the field level healthcare workers, how they are performing. Record maintenance is a very important part on this. We need to record each and every cases. Monitoring and evaluation of this program performance can be done by the indicators. We need to identify some indicators, and we need to calculate and know the exact situation of that program situation. Training is very important part. We need also to implement the NICUS, that is a online real-time recording, monitoring and supervision platform for the leprosy cases. Let's see the job responsibilities. So medical officer will be the overall in charge at PHC level. He will plan the NLEP activities in his domain of work. He will confirm the cases, diagnose the cases, provide appropriate treatment. He will manage the lepra reaction cases and complications. He has also responsibility to provide the on-job training to the PHC staff, and he is the authority for ultimate supervision and monitoring of the leprosy program. Apart from that, he will review all the activities going on in his area, and he will provide the feedback to the district nucleus team. Next is healthcare staff team. So they will assist medical officers in identification of the suspects who can have leprosy. They will also ensure about the availability of multi-drug therapy drugs. They will provide these drugs, and they will also check the compliance in a leprosy patient. They will maintain the records related to the leprosy cases, and apart from other data related to the leprosy, and they will prepare the reports related to that. Apart from that, they will do the IEC activities in the community and DPMR activities as well. Next is the ASA or Anganwadi worker. So ASA or Anganwadi worker will also help in identification of the suspects. They will identify the leprosy suspects and they refer it to PHC, and also they will assist in completion of the treatment. Apart from that, they will counsel the patient, they will perform the IC activities, contact screening, and they will also help in active case detection campaign. Let's see the job responsibilities at district level. So at district level, district nucleus team, this is the core center for NLEP, that is headed by a DLO, district leprosy officer, with other supporting staff. Their main function is to prepare the healthcare workers, that is capacity building. Another work is supervision, monitoring and evaluation of this NLEP program at district level. They will also focus on fund utilization about the leprosy, and they will prepare the statement of expenditure in respect of leprosy. A district program implementation plan PIP that is prepared by a district nucleus team. Let's see some newer initiatives in field of leprosy. So first one is active case detection and regular surveillance, and this will be conducted in both rural and urban areas. Apart from that, three-pronged strategy has been implemented. First one is leprosy case detection campaign, focused leprosy campaign, and in active screening in hard to reach areas. All the three activities are active screening. Third one is convergence of this NLEP with RBSK and RKSK, Rashtriya Bal Swasthya Karyakram, in which we include the child of age group 0 to 18 years, and in RKSK, Rashtriya Kishore Swasthya Karyakram, we include the children of age group 13 to 19 years. Next is convergence with CPHC, Comprehensive Primary Health Care Scheme, in which Ayushman Bharat Yojana is there, and here we include the persons with age group more than 30 years. In both the kind of convergence, the healthcare staff use CBSA, that is community based assessment checklist, to screen all the beneficiaries of this age group. The next one is contact tracing of high risk contacts and provide them immediate post exposure prophylaxis by rifampicin if required. Next one is immunoprophylaxis by using MIP vaccine. It is a newer vaccine introduced recently for immunoprophylaxis. The next one is DPMR, disability prevention and medical rehabilitation. In this, we will provide the dressing materials to the patients. We will provide them self care kits. Also, we will provide them the medicines, supportive medicines. We will provide them MCR, microcellulose rubber footwears. We will provide our healthcare staff training in respect of DPMR, and also the correction of this permanent disability will be done through the reconstructive surgery. And for this reconstructive surgery, 112 institutions have been identified. Out of that, 60 are of government institutions and 52 are run by the NGOs. In this, we will provide medication free of cost. The surgery will be free of cost. Apart from that, the patient will be provided incentive of rupees 8,000 for the surgery, and this RCS, reconstructive surgery, will be conducted at medical college level or any district hospital level or any center leprosy institute level. Apart from that, there has been one guidelines related to the certification and award at district level. So in this, we will facilitate the healthcare team, healthcare echelon, which has achieved the potential leprosy elimination level under the NLEP. So in this, we have divided them in silver category, gold category as per their achievement. Apart from that, case prizes are also provided. We will provide them recognition certificates. Apart from that, newer initiatives, implementation of NICUST, which is an online platform for the real-time monitoring supervision of the leprosy cases. Let's see the challenges we are facing with NLEP. So we have a weak link in establishing the transmission chain of leprosy, as it has very long and variable incubation period. In leprosy, there are many subclinical cases which doesn't show any kind of sign and symptoms, so they are very difficult to diagnose. There are many reactions with multi-drug therapy, and also nerve damage are associated with the leprosy itself. We don't have any effective vaccine as of now. We need to train the manpower. We are lacking the trained manpower. We need to train the trained manpower, and also we need to involve the healthcare workers in the National Leprosy Eradication Program. Drug resistance is another hazard, so we need to introduce some new drugs and regimens for the treatment of leprosy in future. There are many hidden cases in the community. Still, persons are less volunteer to report their cases, so case identification is also a challenge. Although there are many activities for reducing the stigma and discrimination, but still in community we have sufficient level of stigma and discriminate, so that we can forward go back in NLEP to achieve the objectives and indicators. We are facing the reduced number of notification from the private providers. Disability is a great challenge in leprosy. This causes loss of productivity and again we need to enhance our DPMR activities. Still, our monitoring and supervision in field of leprosy is weak. In India, there are very hard to reach areas, difficult to reach areas, very tribal areas are there. So that again there is difficulty in detection of cases. Still, there are a very higher number of migrants in India. This is also a challenge. We need to enhance our research in field of leprosy. Need to develop new tools in which we are still lagging behind. Already I have mentioned about the drug resistance, and also there is reduced resource allocation in the field of NLEP in respect of manpower, in respect of fund, and in respect of other resources. These are the key issues related with the leprosy. So early case detection is a key issue. Contact surveillance is also a very bigger factor. Child leprosy is a big challenge. Identification of visible deformity is also a great challenge, and post-exposure prophylaxis coverage is still less in India. Urban leprosy, increasing in number of urban leprosy is also a great challenge. Capacity building is a must requirement in future. We need to provide a quality of service under NLEP, and lastly, the disability prevention is also a great challenge. So now we are at the end of our presentation. Thanks for watching this video.